Okay, so my name is Teodóra Filipov. I am a PhD student at the interventional radiology department at Semmelweis University, and my vision is to lower patient discomfort by offering them minimally invasive treatment options and less invasive diagnostic tools. And I want to reach this by staying up to date and researching novel interventions. As an overview, I have two ongoing projects right now. One of them is a meta-analysis, and the other one is a protocol for a clinical trial. Let's start with the main project that is about the assessment of kidney transplant patients. Right now, I have completed writing the manuscript, and my supervisor and SMS are looking into it. We plan to submit this paper in the clinical journal of the American Society of Nephrology this month. Yes, a little bit about the background. So interstitial fibrosis and tubular atrophy are the common endpoints of processes that cause kidney dysfunction, and this is the most common cause of allograft failure. And it already starts very early, instantly after transplantation. And the only gold standard method right now for assessing changes in the transplanted kidney is biopsy. And although they are considered fairly safe, they are still invasive, and they are also limited by a smaller sampling size. So shear wave elastography is a promising new diagnostic method for fibrosis and dysfunction. The basis of shear wave elastography is a dynamic force being put on these tissues, and tissue disformation causes shear wave propagation, and by detection of the speed of these shear waves, we can calculate the stiffness of a tissue. Our question was if there is correlation between shear wave elastography and other kidney dysfunction parameters. And after our systematic search in the fall, we were able to include 12 articles into this meta-analysis. Regarding our results, we asked for subgroup analysis based on the method of correlation calculation in these articles because they are quite different. Spearman's correlation assumes a monotonic relationship between continuous variables, and Pearson's correlation assumes a linear correlation. So these two methods cannot be pulled together. But as we can see from our first and most important result, where we assessed the correlation of elastography with fibrosis according to biopsy results, we can see a moderate positive correlation between these two parameters, and the results are, but the populations of these studies are quite heterogeneous. So obviously that is a limiting factor, but nevertheless, these are pretty promising results, and we can probably use this method in the future. For our second question, we wanted to assess the correlation of elastography with the resistive index of arteries. This is the RI is a calculated flow parameter. It measures the resistance of intrarenal arteries. And here we awaited a linear correlation between these two factors, but as we can see, results are really heterogeneous and contradictory. So it is possible that these two factors are independent from each other, and yeah, we can see what we will do. Okay, sorry. And as kidney function declines, creatinine increases, which is a very important factor in assessment of kidney dysfunction. Also, here we can see a moderate correlation as well, but creatinine increases in the later phases of dysfunction, so it is not able to assess early dysfunction. As a conclusion, we can say that biopsy results correlate positively with elastography, and because of the more superficial location of transplanted kidneys, higher quality images can be obtained. But elastography findings have to be interpreted together with other factors. And in the future, further research about the sensitivity and specificity of this method is needed, and also the development of software specific to the kidney. Yes, this is the first meta-analysis assessing the correlation of these parameters, and we also provide a detailed renal function assessment, but there are also several limitations to our study. As for the second project is a protocol for an interventional trial, the percutaneous ultrasound-guided cryoablation of fibroadenomas. Fibroadenomas are really common palpable masses in women's breasts, and they are very common in younger women, but it can occur at any age in premenopausal women. And traditionally, these lesions are treated surgically, but that can be a problem with, of course, if a woman has multiple lesions and that causes scarring. So there is increasing evidence that the cryoablation as a minimally invasive approach is a feasible and good method that is fast, painless. It can be delivered under local anesthesia in a doctor's office, an outpatient setting, so it decreases the risks of surgery. This is also a question. We wanted to see how effective cryoablation is in the management of fibroadenomas. But what is this cryoablation? This method, for the intervention, we will use the ProSense device by iScure Medical. It is a device that uses liquid nitrogen flowing in a closed system in a probe. And this probe is inserted into the center of the lesion, and the flow of liquid nitrogen creates an ice ball around this lesion, and the edges of the lesions are at lethal temperatures, which cause a change in osmosis and causes cell membrane damage, and that results in cell lysis and cell death. And that tissue is then being absorbed by the body. Our follow-up times are going to be 1 month, 6 months, and 12 months. We will include women above the age of 18 who have core biopsy-proven fibroadenomas that don't exceed 6 centimeters. And of course, malignant tumors in the same breast are going to be excluded, also as suspicious lesions and acute inflammation cases. And our main outcome to assess will be the degree of volume reduction of the residual fibroadenoma, and also secondary outcomes are going to be about palpability and overall patient satisfaction with this method. We are waiting for a meeting with the International Trial Advisory Board, and after that we are planning to submit the 2CAB forms. And yes, we want to submit both of these in June. Let me end my presentation with the words of William Osler, who said that the great physician treats the disease, and the good physician treats the disease, the great physician treats the patient with the disease. Thank you.
I was thinking about your second project, that you were saying that currently the first approach would be surgery. And your primary outcome actually is that if there is a reduction in size, at least 50%. But you are not predicting that it will like disappear. Like, I mean, in the surgery you will excise it and you take it out, of course, then kind of the response rate is 100%. And in the other cases is about 50%, but it's not even 100%. I'm just thinking about the place of cryoablation there in this question.
Thank you for your question. It is very important to say that even with a surgical excision, some parts of these lesions can be left in the breast that can reactivate. And with cryoablation, of course, most of these lesions, as we see from previous data, they have a minimum of a 90% reduction by the end of 1 year. So we set the point at 50% to be able to measure a significant reduction, because 50% reduction is quite high, but we await more than a 70% reduction of these lesions in the end. So it is a feasible method, and also these lesions become not palpable, and also only the cryo lesions are left in the breast that is only viewed under ultrasound. So it is safe and also doesn't cause scarring that much.
So we are very much interested in these fibromas because, you know, in gynecology, plenty of women, more than 50% of women have myomas, so fibroids. We are very much aware whether this method could be used also for uterine fibroids. And then, so the maximum diameter is around 6 centimeters for this method?
Yes.
Is it sure, or is it an arbitrary one, or you just decided this 6 centimeters, or?
Well, we decided 6 centimeters because that already is a very... So this causes cell death and cell lysis in the tissue. So that is already a quite big feeding ground for bacteria, if there is any. So, and also these are really big. So if you just kill the cells there, it has to be safe. So 6 centimeters is what we decided on.
Yes, and the other thing is that you mentioned some hydrodissection from the skin and some safety distance from the skin.
Yes.
Why is it that?
We use saline, sterile saline for hydrodissection, just to be sure for not having any skin lesions because of the cold of this ice ball. So it is safe to maintain like a 1/2 or 1 centimeter border around this fibroadenoma.